Okay.
Any questions, comments? Legislative analysts?
Thank you, Madam Chair and members. Ross Brown with the Legislative Analyst Office. We agree that more customer assistance resources will likely be needed in order to handle the additional Medi-Cal managed care enrollment. However, we wanted to note that this resource request is partially based on estimates of additional Medi-Cal enrollment, and we expect updated information to be available in the coming months. And so, therefore, our recommendation is to hold this item open and direct the administration to report on some of those updated estimates around the time of the May revise, and how those updated estimates might affect the workload associated with this request.
Okay, very good. Thank you. Department of Finance? All right. Yes. Senator Walters.
Yeah, for Department of Finance. So just looking at my notes here, it says that there's a request of 2 positions and a reduction of $50,000. So if we hire 2 people and we take a reduction of $50,000, though, hiring those 2 people, doesn't that require us then we'd have to pay their health care when they retire?
I'm sorry.
Okay.
The question's on the retirement?
So the question is,
yeah.
We want to request 2 positions, and it says a reduction of $50,000. Do we take into account these 2 positions and the fact that when these people retire, we have to pay for their health care?
It does. So there's salary costs built in when we add positions, and then there's benefit costs as well, and sort of a standard complement of operating expenses and equipment expenses associated with any positions, and that includes health and retirement costs.
So you do calculate the health care, the cost for the health care when they retire?
So I think that there are arguments about sort of whether we have fully funded retirement, retiree health, and pension costs and that sort of thing, and I would have to circle back and kind of defer to some of our.
If you could, because it's my understanding you don't take that into account, the health care costs when they retire, that we don't take that into account. So if you could find out and let me know.
We will do that.
Okay,
yep, that sounds great.
And this is in reference to the previous item, number 3, the new customer relationship management system, where there was a request of reduction of $50,000 on, I think it was outside services, and then hiring of new additional individuals. Okay, all right. Thank you very much. All right. So, public comment on this item. Item number 5, individual mandate workload. Or, excuse me. Now I've totally lost my page. Item 4. Back to item 4. I know you know where we are.
Vanessa Hino with the Western Center on Law and Poverty. We would certainly support DMHC in their aggregation of these additional positions. Medi-Cal managed care has expanded significantly over the last several years and will only continue to expand if we keep on the current track that we are, particularly for more complicated populations that will have issues in their delivery system. So we support these positions, and if they want more, we'd support that.
All right. Thank you very much.
Beth Capel on behalf of Health Access California, and we would note that consistent with the LAO's recommendations, we anticipate that when you hear this again after the May revise, you will in fact be hearing about additional positions because Medi-Cal enrollment has been substantially greater than projected, and we are delighted to see more Californians getting coverage, and it means we should give them the help they need to get the care they need. Thank you.
Thank you very much. All right. Recommendation that this item stay open as well. Any objections? All right, we'll move on to the next item, which is item 5, the individual mandate workload.
Yes, thank you. This legislative proposal would provide 13.5 positions for fiscal year 2014 and 15, and 19 positions in 2015-16 and ongoing. All these positions would be located at the Help Center to assist those individuals who are now covered through Covered California in the individual market, as well as in the off-exchange products in the individual market as a result of the Affordable Care Act. With regard to your question about the types of calls the Help Center's been receiving related to the individual market, from January 1st through March 10th of 2014, the Help Center's been contacted by 1,149 healthcare consumers for issues related to changes in the individual market. The top 6 issues the Help Center staff have identified are, first, the enrollee did not receive their enrollment packet or identification cards. That represents about 17% of the issues. The enrollee was not able to confirm their enrollment with the plan or Covered California, which is about 16% of the issues. In 12% of the issues, the enrollee was not able to access care, and another 9% the enrollee was not able to access medication. So together, that's about 21% of the calls were related to direct access to care. 7% the enrollee could not reach the health plan, and 6% the premium amount due was different from the amount quoted by Covered California. While some of these cases are still in progress, the department has been able to successfully resolve most of the consumer issues, primarily because we've developed a direct connection with some of the health plans so that we can get to people quickly and get these issues resolved on their behalf. Any questions?
Do you have any questions, comments? All right. LAO?
Our recommendation on this item is similar to the one on the previous one. We recommend holding it open as more updated enrollment information becomes available, and it could be reassessed around the time of the May revise.
Okay, thank you very much. Department of Finance? All right, public comments.
Beth Capel on behalf of Health Access California. We are delighted that Covered California has enrollment that has exceeded the projections for the end of this year. It has already exceeded. This is a good thing, so we expect when this item comes back to you, they will be seeking additional positions. We would also note, as Director Roulard indicated, that the department has for many years had the capacity to reach directly to a health plan 24 hours a day, 7 days a week in order to resolve consumer complaints if they are urgent. And we are pleased that they are using that in this circumstance as well. So thank you.
Thank you very much. It's all good news. Any additional comments? No? All right. Then this item is recommended to stay open as well. Everybody okay with that? Okay, very good. Thank you very much for your testimony. Thank you for the good news. Next item, we'll hear from Managed Risk Medical Insurance Board and also 4280 Department of Healthcare Services. First item with these presenters will be the elimination of Mr. Mibb. Good morning. Good morning, Mr. Douglas, Mr. Ramey, and I'm sorry.
Good morning, Chair. Morgan Staines, Chief Counsel, Mr. Mibb.
Thank you very much. All right, please proceed.
Good morning. I'm John Ramey, the Executive Director of the Managed Risk Medical Insurance Board. The agency was initially formed to provide a program for high risk, to create a high risk pool in California under a bill authored by Assemblyman Eisenberg, signed by George Dubagin, and the Managed Risk Medical Insurance Board, which became known by its acronym Mr. MIB, is governed by a 5-member board, 3 appointed by the governor and 1 each by the Assembly and the Senate. In succeeding years, after the high-risk pool was formed, the board was assigned to develop and administer a succession of programs. The Health Insurance Purchasing Cooperative, which was a small group purchasing cooperative, and then came the Access for Infants and Mothers program. And then after that, the Healthy Families program. The legislature has seen fit to have the Mr. Mibb administer these programs for a variety of reasons, but one of which is because it's a public board and meant in open public meetings, it needed to follow the open meeting laws of the state of California, and so the process and the development of these programs was a publicly viewed, transparent to stakeholders. In terms of the governor's proposal to terminate the board and its programs, it's, the mission of Mr. Mibb over all these years has been to find ways to get uninsured Californians coverage. And it's easy, I think, to see from the governor's perspective with the expansion of the Medi-Cal program, which he has agreed to and is supported, and it is occurring and in a very robust fashion has been mentioned, which is wonderful. And the creation of the Covered California exchange in California, which is also covering the uninsured and those without coverage. It's, I think, from a broad perspective, easy to say, well, how many of these entities do we need doing providing coverage for the uninsured, and that from that perspective, it is say that perhaps we don't need the smallest and least significant of the entities that we do. And one of the things that Mr. Mibb did differently is that traditionally the state had paid for medical care, through a claims processing and claims payment process. And Mr. Mibb did it differently. It did it through a healthcare purchasing perspective, in which it tried to go out and into the market and purchase healthcare coverage on a competitive basis in the market. And increasingly, over time, Medi-Cal has become much more of a purchasing entity rather than just a claims-paying entity, and the exchange is certainly an active purchaser. So the time has come.
Thank you very much for your presentation. Any other comments on that item by the panel? All right, any comments by members? Senator Bonning?
Well, I want to thank the panel in the presentation, and I think also just to underscore that one of the reasons for this transition that was, I think, implied in your presentation, but the Affordable Care Act specifically prevents a plan from denying coverage because of a pre-existing condition. And I think that, among the other reasons cited, is probably the primary reason for the timing for transition, but the continued need for some high-risk access, even with a transition, I understand is for somebody who's missed an enrollment period but may have serious medical needs. They would still have the potential to pursue coverage through a transitioned program. Is that accurate?
Yes, it is.
Thank you.
Yes.
I think it's also important to answer one of the other questions that was raised and implied. One is, why do we still need another full year of funding for the program? And also, give us a few more details on the actual transition and elimination and how that will all roll out.
Yes, Madam Chair. Morgan Staines, Chief Counsel at Mr. Mibb. The budget proposal is somewhat a point in time. At the time that it was prepared, there were more unanswered questions about what the Mr. MIP program would look like as the year rolls out, and that's why a full year was put in. One aspect at that time also is that due to our participation in the federal pre-existing condition program, the PSIP, that program, that contract with the feds had a maintenance of effort requirement on Mr. MIP. That is technically still in place, but the conditions that made it necessary from the federal perspective are pretty much gone. The federal PSIP program is just about gone, and indeed they're not accepting any new enrollments in any event. So the maintenance of effort issue is gone, and we are now seeing a fairly dramatic reduction in enrollments in the Mr. MIP program.
Hi, Toby Douglas, Director of the Department of Healthcare Services. In terms of your, well, first on that, as part of the May revision, we'll definitely be looking at that, what Mr. MIP again, and as we have had the implementation of Covered California and Medi-Cal expansion, to see what we do in new estimates and the future of the Mr. MIP program. And that gets to the second piece. So we have been working with Mr. MIB over the last year on transitions of, in particular, of the Healthy Families program, as well as the staff, the remaining staff. And we recently kicked off for the remaining staff looking at the transition of staff as well as those programmatic responsibilities into the department. We will be posting information and engaging stakeholders in the process over the coming months on that transition. But two important pieces for the programs. The idea is to transition them as is. We are not trying to change, and similar to what we've done with alcohol and drug program, the department when we transition, we're not changing the programs. The staff will come over and be under my responsibility. So we will keep your staff engaged as well as stakeholders. Information will be posted to make sure we continue to have a smooth transition as we've done previously with other transitions.
Okay, thank you. And are we going to also hear a little bit more specifically about integrating the Access for Infants and Mothers program into the CalHERS enrollment system and how that transition and integration will occur?
Sure. You want to take the first step on the current situation, and I'll talk long term.
Yes, I'll address what we're doing presently, and Mr. Douglas will address the future.
Okay, thank you.
What happens now is the CalHERS produces an application data extract for us, hard copy. This is it's a paper process at this time. We cast a wide net. If an application indicates a pregnant woman, they extract it and send it to us. We receive those on a daily basis, and then we plug those into the AIM application process, which has a long-standing and pretty significant missing information process to gather the rest of the details that are needed for any particular application, and these are put into it, and these always have missing information. That is the nature of the conditions on the ground at this time. The missing information process contacts the applicant in writing, by letter, and by up to 5 phone calls at different times of day, different days, to maximize the opportunity to make contact with that applicant and gain the additional information to complete their application in a timely manner. Then our process does have the capability now to use the CalHERS connection to the federal hub to make the income determination using the MAGI rules. And so we do that. If the electronic process is not successful, we follow that as CalHERS does and Covered California does. If the electronic verification is not successful, it's followed up by further contact with the applicant to attempt to complete it on a paper basis.
Well, so the long term, I'll address 2 pieces of it. So the AIM program, as I said, will move over to the Department of Healthcare Services. We are, to align with Affordable Care Act rules and modified adjusted gross income, we are looking with Mr. Mibb on some of the eligibility rules to be in compliance with all federal rules, and there might be some modifications, for example, on requirements on, right now, on if you apply late in your pregnancy, then you're not eligible. We're having to look at that again if that comports with federal rules. The other piece relates to the overall vision of the administration of making this as consumer friendly as possible and not having multiple programs. We have in Medi-Cal many pregnancy related programs. In essence, what this program does is provide pregnancy services to a higher income group. So coming through CalHERS or being promoted by Covered California, we want simple messages of you're eligible for affordable health coverage, either advanced premium tax credits or Medi-Cal. So while the program will stay pretty much the same, the name we're proposing to change it to a Medi-Cal name so that there aren't all these small little programs that make it more confusing for consumers. that gets to the second piece of CalHERS, and how we want to program this all into CalHERS. What Morgan laid out is not the most optimal approach. That being said, we have many system changes going on within our CalHERS systems, interfacing with our SAS. It's been, on the positive side, we stood up this system with Covered California, and we've successfully enrolled millions of Californians. The other piece of it is that we haven't gotten everything done that we want to. So we're having to prioritize on the most urgent needs. And so we want to get this in as quickly as possible, but it's dependent on getting the urgent fixes into the system that relate to work with our county partners, different defects within the system. And so we will keep you and your staff apprised of when it gets into the system.
Okay, thank you. Are you fairly confident that there won't be any disruption in services for individuals, mothers, and infants as we transition through?
Transition to the department?
Yes.
Yeah, well, I'm confident. Similar to, we've gone through several other transitions, and we will make sure that we do this in a way that does not disrupt care.
Okay. We'll all be working together to hopefully make sure that happens. Any comments by LAO? Thank you very much.
Thank you, Madam Chair. Sean Martin, Legislative Analyst Office. In our analysis of the governor's budget proposals in the health area, we described some general principles of when government reorganization, such as the elimination of the Managed Risk Medical Insurance Board, makes sense. And Senator Monning will probably remember me discussing these same principles when we were talking about the elimination of the Department of Alcohol and Drug Programs. First, does the reorganization maintain or improve efficiency by eliminating redundancies or overlapping or duplicative processes? Second, does it maintain or improve effectiveness? And this could be by improving government services as they're provided to the public. Third, does it maintain or improve the accountability of the organization? Fourth, is it based on a policy rationale? And does it reflect legislative priorities? So we looked at this proposal in terms of those general principles. We didn't find that it would immediately improve efficiency or effectiveness. As it's been described to us, it's a lift and shift, where they're taking the existing resources from the Managed Risk Medical Insurance Board, moving them over to the Department of Healthcare Services. But the Department of Healthcare Services did indicate discussions that as their managers had more experience with these programs, that they thought that they would be able to identify efficiencies and improve effectiveness. It is unlikely that it would improve accountability, and that's because the Managed Risk Medical Insurance Board currently holds monthly meetings where they provide a significant amount of up-to-date data about the caseloads and how programs are operating. And our understanding is this would no longer occur. Also, it's uncertain to us whether the Department of Healthcare Services would provide the same amount of detail about the budgets for these programs in January and May as is currently provided by the Managed Risk Medical Insurance Board. With regards to whether there is a policy rationale for making this, we do believe that there is a policy rationale. I think they've already outlined that to you, so I'm not going to go into it in further detail. So as we looked through this proposal, we thought that they made a case for doing this, but that it wasn't an especially compelling case. We do recommend that they testify on how they could potentially improve effectiveness and efficiency and what steps they'll take to ensure that the current levels of accountability are maintained.
Would you like to respond to any of those comments?
Well, in terms of effectiveness, I think it comes back to the department with, the leadership that we have in our department of running similar programs, that there is value in bringing those like programs together and having a team that can operate those programs, and that isn't just about effectiveness in terms of dollars saved, but having the right individuals are looking at the big picture. And that's, once you start having, Mr. Mibnow is down to a small number of staff, there's risks associated with leaving them alone, with staff leaving, going other places, and that you bring it into an organization that has that structure and a strong structure remaining. to serve these remaining programs, as well as look at how they fit into the broader health delivery model.
Okay. Thank you. Yes, Senator Martin.
So with the LAO's reference to oversight that would be lost with losing the Mr. MIP board, how do you maintain that oversight and accountability?
Well, that's an ongoing commitment from the department that we're looking at and continuing to strive to provide more transparency on what we do in terms of everything from dashboards and providing metrics and information to looking at our overall stakeholder engagement and how we structure our engagement. And so we would be looking for, as it relates in particular here, both to pregnancy-related services, on what metrics we provide. Clearly, the Medi-Cal program already, we provide 45% of all births in California, and that's growing with the Affordable Care Act. So there's a focus, and how do we continue to provide more visibility in these areas? And the same goes for children's health and the high-risk pool. We serve, and I'll talk about it. We have chronically ill children and adults programs. So how does it fit in? But the commitment is there to continue to work as a department to provide more transparency, more accountability, and more consumer engagement.
And there are formal mechanisms for that stakeholder
We have
engagement.
many stakeholder mechanisms that what we're looking, stepping back, is how do we create even more organized structures. We've had, we have over I can't remember the exact amount, but multiple stakeholder groups that meet. It's a matter of the structure and forms also to make sure that there's the ability for stakeholder input, and taking that and looking at how our programs are structured. We're doing that, for example, right now a lot on the eligibility changes that are going on and the guidance, and we'll talk about eligibility and enrollment and all the changes that are going on. And so we have an ongoing weekly consumer engagement on that. On the mental health and behavioral health front, we're creating, and we're starting next week with a whole mental health forum. So it's many different structures, and creating from those structures not just the input, but then the accountability of follow through, similar on the coordinated care initiative.
Thank you.
And then my last question would be, since we don't have I know you're working on the transition plan, we don't have like a in-writing detailed plan yet. When might we expect to get some of the, important components? Are we looking at the transitions in July, right?
Yeah.
So
in the next, next 4 to 6 weeks, we'll get more information to you.
okay, all right. Well, we'll look forward to that, and we'll keep you to that.
Yeah.
Thank you very much.
Okay.
Any other comments? Department of Finance? No? All right. Public comments? Please come forward.
Good morning. Thank you for the opportunity to comment. My name is Lynn Kersey. I'm the Executive Director of Maternal and Child Health Access in Los Angeles, where in one program alone we see over 2,000 births a year for case management and home visitation, and enrollment into programs such as AIM and Medi-Cal and Covered California. We have technical amendments that we've submitted that will be taken up elsewhere, I know, for the AIM program specifically. But we do oppose the name change. We know that AIM was left out of the CalHERS enrollment process over some time ago, and it's been a clawback and a struggle ever since to make sure that that program gets the recognition that it has had. It is a comprehensive program, all covering fully all that women undergo, not just pregnancy. So we think it's very different and distinctive and should remain that way. We appreciate and support that the department is aligning with many Medi-Cal rules, such as coming in late in pregnancy. We don't think women should forego their last 10 weeks because they enroll late in the game. And it takes, by the department's own, CalHER's own statistics, it takes 3 or 4 tries at Covered California to get all the way through. So we appreciate that change. But we don't support the name change. Thank you.
Okay, thank you very much.